Okay, we're doing Rehabilitation and Restorative Care. That's our Chapter 9, page 220. Chapter 9, page 220. In our Hartman book. Discuss rehabilitation and restorative care. When a resident loses some ability to function due to illness or injury, rehabilitation may be ordered. Rehabilitation is care that is managed by professionals. It helps restore the person to his highest level possible level of function. Underline that. Rehabilitation is care that is managed by professionals. It restores the person to the highest possible level of functioning. To help a resident regain function or recover from illness, that is what rehabilitation program is used for. To help the resident regain function or recover from illness, promote independence, to make them feel in control of their life, and to accept or adapt to the limitations of their disability. Sometimes they can't get them all the way there, but we're going to try to. Restorative care is usually followed by rehabilitation. Restorative care actually keeps them at the level that we got them in rehab. So in order for us to be good caretakers, as a result of our care, we should never have a patient go bad. We got to keep them at the level of care that we got them to in rehab and keep them at that care. It should never go any other kind of way. Be patient with their during restorative care, especially. Progress may be slow. Just help them out. Be positive, supportive. Focus on small tasks they might not be able to do so much. Break them down into simple, small steps. Recognize that setbacks occur. Progress still can happen. Sometimes, that you might overwork them a little bit too much and they got a little pain going on, so the next day they won't be as happy to work as hard. But just know that that's progress. Be sensitive to the residents' needs. Some may need more encouragement than others. Some are embarrassed by encouragement. Some don't want you to be, yay, they did this or that. But encouragement is always a good thing, most of the time. Encourage independence. Independence improves self-image. Also involve the residents in their care. Let them know what they're going to do. Let them know what their plans or goals can be. If we do this daily, if we do this every other day, then we're going to have you walking by the end of the month, possibly. You try your best to encourage them like that. Observe and report any increase or decrease in their abilities, any change in attitude or motivation, even positive or negative, any change in general health, such as changing in skin condition, appetite, energy level, or general appearance, any signs of depression or mood changes. Sometimes people are hurt so bad or had a stroke that it's messed them up pretty bad and they get depressed. And we're trying to get them back. So report that, I should say. Describe the importance of promoting independence and list ways exercise improves health. We already know that if we do not exercise or if we do not keep activities going, that the patient can go down. Maintaining independence is vital during and after rehabilitation services. Then we go to restorative services. When an active and independent person is dependent, physical and mental problems may result. They become less mobile. Inactivity and immobility can result in many problems. It can be self-esteem, depression, pneumonia. We've already talked about this. Urinary tract infection, constipation, blood clots, dulling of the senses, muscle atrophy, contractures, increased risk for pressure ulcers, problems with independence and self-esteem. In our previous chapters, we've discussed almost all of those. So it's our job to keep the residents as active as possible because we know that regular ambulation and exercise helps improve quality and health of the skin, improves circulation, strength, sleep, relaxation, mood, their self-esteem, their appetite, their eliminations, blood flow, their oxygen level, all that. That's why we got to keep them moving. Ambulation is walking. A resident who is ambulatory is one who can get out of bed and walk. Sometimes they have to use tools to walk. Gait belts, canes, walkers, crutches. However those are, they help with ambulation. We try to get them going as much as we can. If you look at page 222, we've already done that skill most likely. And that is something you should read. What I want y'all to focus on is why you do what you do. Do you do skill, and it has so many steps, and at the end of that step or behind the step, you'll see italicized, and it'll tell you why you do yourself, such as why you wash your hands. That is number 2 on page 222. It provides for infection prevention. Explain the procedure to the resident. Speak clearly, slowly, and directly. Maintain face-to-face. That promotes understanding and independence. Provide for residents' privacy with the curtain, screen, or door. It maintains the resident's right to privacy and dignity. Adjust the bed to its lowest level so that the feet are flat on the floor. Lock the bed wheels, especially when you're transferring anyone. It prevents injury and promotes stability. Number 6, before ambulating, put non-skid footwear on the resident and securely fasten. That promotes resident safety and prevents falls. So everything you do, I want you to look at that, and you know the skill, but I want you to understand why you do each step of that skill. Okay? When helping a visually impaired resident walk, the NA should let the person walk beside and slightly behind. So you're walking in front of them. The person walks slightly behind you because you want to experience the steps before they do. Sometimes it's okay, here's a little bump in the road, pick your feet up a little higher. When they can't see, you need to describe those same kind of things. Or how this step's a little steep, so you just know that it's not just right there. And you have to explain that to them. Also know that a cane should be held in the strong side or the strong hand. And if you look at figure 9.5, that is a quad cane. It gives a lot of stability. The quad cane has 4 rubber tipped feet and can bear more weight than other canes. Those are the ones, especially when someone is unstable, but somewhat stable. That sounds different, but it's better than a cane because it has a lot more stability. A walker used when the resident can bear some weight on the legs. The walker gives stability for residents who are unsteady or lack balance. The metal frame may have rubber-tipped feet or wheels. Crutches are used for residents who can bear no weight or limited weight on one leg. So you can use one foot to actually walk on crutches, but maybe that other leg is up in the air. The photo on the left shows a standard walker, and the photo on the right shows a hemi walker, which is a walker that is designed for people who have difficulty using an arm or a hand. And they're just different, but still the same. They're both walkers. A cane or walker used. Be sure the walker or cane is in good condition. It must have rubber tips on the bottom. They won't those, you think that's weird, but they have tennis balls a lot of time on the bottom of them. And that's for traction, that's for friction, instead of them slipping everywhere. Also, page 224, be sure the resident is wearing securely fastened non-skid shoes before you pick them up. Make sure the bed wheels are locked. Make sure the wheelchair is locked. Make sure the cane is in their stronger side. Both hands need to be on a walker if they're walking with the walker. Stay near the resident on the weaker side. You need to walk on their weaker side just in case that's where they're going to give way at. Do not hang purses or clothing on the walker, and you see that a lot, especially with your elderly. They push right along with their pocketbook right on top. If height of the cane or walker does not appear to be correct, too short or too tall, make sure you adjust that for them. Assisting with ambulation for a resident using a cane, walker, or crutches. And each one are different. You still, for using, look at number 10 for a cane. The resident places cane about 6 inches or a comfortable distance in front of the stronger leg. Then they bring the weaker leg even with the cane, then brings the stronger leg forward slightly ahead of the cane. So you are walking, you are stepping with the strong leg, bringing your weak leg. Walker. Make sure that walker is at least 6 inches or at least that somewhat amount in front of the patient, and then they walk into the walker. Then 6 inches. You don't want it extended more than that because then they'll be unstable for a second. So at least 6 inches. For crutches, you're going to make sure that they are fitted to their axillary or their axilla area. You don't want them all up in their arms. That will cut off circulation to the arm. You want it just below it. And it's really there for stability. You don't want to lean on it. That will mess you up. No matter how they're used, weight should not be on the resident's, or weight should be on the resident's hands and arms, not on the underarm area. Always look for obstacles in their way. Look for anything that could be safety related, wet spots. Anything like that can cause a very bad mishap. Sometimes we're having to use assistive or adaptive devices. If you look, there's several devices here that we can use. Long-handled grippers to pick up their pants. The lady at the bottom, she's put her foot in the little adapter to put her foot on the bed. Maybe she cannot reach or she cannot lift that leg, but with that she can. And that's are your adaptive equipments. Explain guidelines for maintaining proper body alignment. Proper body alignment pretty much puts everything in a straight line. Your feet need to be in a straight line. Your hands need to be in a straight line. Your feet need to be at a 90-degree angle. Even when they're laying on their side, these pillows are making him be in correct body alignment. Observe principles of alignment. Proper alignment is based on straight lines. Make sure that pillows or rolled or folded blankets can support the small of the back and raise the knees. However, keep them in proper body alignment. Keep body parts in natural positions, natural hand positions. The fingers are slightly curled. If they've had a stroke, a lot of times we'll put something in their hands so they do not start contracting in, and that can cause their hands to mess up. Again, we already know that we're going to change position every 2 hours. Amputation happens. Sometimes a result of diabetes uncontrolled or infection. It could be an injury or accident. But amputation is the surgical removal of some or all of a body part, usually a hand, arm, leg, or foot. We got to know that they may feel pain in the part that has been amputated. They call that phantom sensation. It's a term used when a person feels that body part is still there. Phantom limb pain occurs when the person feels pain in a limb that has been amputated. Kind of the same things. They're kind of feeling that it's still there and they having pain there. You want to know that that is real pain. The nerves that used to go to the foot no longer go to the foot. It is stopped at the knee. They cut it there. They don't pull that nerve. They just cut it. So sometimes, your body does things, and I'm sure maybe they get swollen, and it can mess with that nerve that used to go to the foot. And that may be where the pain comes from, but it's not foot pain, but it feels like foot pain. And it is real pain. A prosthetic is a device that replaces a body part that is missing, a prosthetic. Artificial limbs, hands, arms, feet, and legs, all are artificial body parts. They are prostheses. Even artificial breast, a hearing aid, artificial eye, dentures, all of them are prosthetics. It helps improve some kind of way. It helps also appearance of deformities. Amputation and prosthetic care. Resident who has had a body part amputated must make many physical, psychological, social, and occupational adjustments due to disability. D and tongue-tied. Help residents with their ADLs. Prosthetics are specially fitted, very expensive underlying net equipment. We have to handle them carefully. A therapist or nurse would demonstrate application of the prosthesis. A lot of times the patient knows more than you do about how to put on their body parts because they have been trained to do so and they know how to do it. And they know what feels comfortable to them. Remember that phantom limb pain is real pain. Treat it that way. Do not think that it's not. Sometimes they have a stump sock. All that is wherever their body part was cut off, it's just like a sock that we put on our feet. They put it on their limb, whatever part of the limb, and then they put on, just like we put on our shoe, they put on their body part. And that's what that stump sock is. Describe how to assist with range of motion exercises. Range of motion exercises put a joint through its full arc of motion. The goal of these exercises is to decrease or prevent contractures or atrophy, improve strength, or increase circulation. So the goals are to decrease or prevent contractures, so range of motion helps contractures, improve strength, and increase circulation. There's 3 different kinds of range of motions. You've got your active range of motion. That's done by the resident. The resident is active, so active range of motion. The resident is active. Then you have your active assisted range of motion. That means that they are being assisted, but the patient is also helping. And then you have that passive range of motion. That's where the residents are not able to move on their own. They are passive. So active range of motion is the patient is active. Passive range of motion, patient is passive. That means you're going to do the work. You're going to do all the range of motion exercises. And look at page 227, abduction. It's kind of like we've already talked a little bit about this. Abduction is taken away, and that's a range of motion. Adduction is adding it back. Extension is just like extending your arm out. Flexion is like they're flexing their muscles of the biceps, so they flex it, they bend it. Dorsiflexion means bend backwards, like we would do our foot on one of the skills. Rotation just means turning that joint. Pronation is turning it downward. Supination, what would you think? Turn upwards. And opposition is just moving those fingers. And those fingers are opposite each other, and you're using all the range of motions for everything. Even down to the various little bitty joints of the fingers, you would move them as much as you can, because that is their range of motion. Even down to their toes. If they have a joint there, we're going to make it work. NAs will not do range of motion exercises without an order from a doctor, nurse, or physical therapist. They may repeat each exercise 3 to 5 times, once or twice a day. It really depends on what's ordered. Working on both sides of the body. You would do both sides. On our state skill, we only do one side, but you'll do both. And if you just look at page 228, you're just going through the range of motion exercises on every body part, on every part that can bend, turn, twist, whatever it can do. That's what we're making it do. Straighten the toes, curl the toes all the way down. Toes go out, fan out a little bit, then they come back. Same with the hands. They go out, they come back. You can push them back, you can push them forward. You can bend at the first joint, you can bend at the second joint. Do what they can do, all you can do for them. List guidelines for assisting with bladder or bowel training. Injury, illness, or inactivity may cause a loss of normal bladder or bowel function. Residents may need help to reestablish a regular routine and normal function. Problems with elimination can be embarrassing or difficult. NAs should be sensitive to this. They should be professional in handling incontinence. Never snarl up your nose when somebody's, trying their best. Guidelines for bladder or bowel retraining. Follow standard precautions. Wear your gloves when handling body waste. Explain the training schedule to the resident. Follow the schedule carefully. This helps them get a routine. Keep a record of the resident's bladder and bowel habits. When you see a pattern of elimination, you can predict when the resident will need a bedpan or a trip to the bathroom. So try your best to understand when they're going. Offer a bedpan or a trip to the bathroom before beginning long procedures. Encourage residents to drink plenty of fluids. Do this even if they have urinary incontinence. You never withhold fluids even if they have urinary incontinence. About 30 minutes after they've drank fluids, you just know that they're probably going to use the restroom. Same as 30 minutes after they've taken a water pill. They're going to go use the restroom. Encourage the residents to eat foods that are high in fiber. Encourage residents to follow special diets as ordered. Answer your call lights promptly. Residents cannot wait long when the urge to go to the bathroom occurs, so get there as quick as you can. Provide privacy for elimination. If a resident has trouble urinating, try running water in the sink. Same thing they do. Some people have shy bladders. Turn on the water, make some different noise, and maybe they can use the restroom. Do not rush the resident. Help with their perineal care. Make sure if they're trying to do it themselves, make sure they do it. You don't want them just wet and causing ulcers. Discard waste according to the facility policy. Discard clothing protectors and incontinence brief properly. Double bag these items if ordered. Sometimes you don't have double bags, but it'd be nice, because if something breaks, those are bodily fluids that you need to be protected. Some facilities use washable bed pads or briefs. Follow standard precautions when handling these items. Most facilities now do disposable. You use it and throw it away. Keep an accurate record of urination and bowel movements. They will ask you, how many times did they urinate? How many times they had a bowel movement? And that also knows, is their body working properly? Praise the sexes even attempts to control the bladder. Sometimes it's not going to work. Sometimes they don't want to even discuss it, but we're going to, if they don't want to be encouraged, or you sit there and yay for the bowel movement, they feel like they're a child. So try to figure out your resident, but be happy that when you do show improvement, or when they do. Never show frustration or anger. When the resident is incontinent, cannot use the toilet when asked, be positive. Never make the resident feel like a failure. Praise and encouragement are essential for a successful program. Some residents will always be incontinent. You might not be able to fix that, but be patient. Offer these residents extra care and attention. What you do is you will learn your patient, and sometimes you can learn them so well that that after 30 minutes, 45 minutes, let's go sit them on the stool. And the patient will be so much better. They don't like to urinate or defecate on themselves, especially if they have any cognitive thinking. They don't like that. So just know that will help them out too. Changing incontinence briefs. When changing the incontinence brief, the NA should make sure to assemble all needed items beforehand. You do not need to leave your patient standing there wet or with anything on them, including a protective pad, perennial care supplies, disposable wipes, gloves, and a clean brief. She should not put on gloves before handling the brief. When removing the soiled brief, the NA should roll it in the inward soiled side inside without spilling its contents. Working from front to back, she should carefully remove all urine and or feces from the skin. After cleaning the area thoroughly, she should blot it dry and apply a clean brief. Make sure you are drying our residents. They do not dry by themselves. You will have to dry them. That was the end of chapter 9. That chapter is not bad. But we do have to do our passive range of motion exercises for our skills test, so remember that too.